Let's talk about 3 weights. Okay, so this is a photo of 3 weights. Let's go to the drawing. We'll come back to the photo, but we'll look at the drawing and then get the point location. So when we're trying to needle 3 weights, we want to find the back border, the posterior border of the fibula, because it's very easy to find. On some people, the musculature in the calf is such that it's difficult to feel the anterior border of the fibula. So we start with the posterior border, then we know where the anterior border is. And then we put our second finger on the anterior tibial crest, coming down the middle of the tibia, the pointy edge, that's called the anterior tibial crest. And then between the front of the fibula and the anterior tibial crest is first weight. There's a pool of energy there. There's an indentation. There's a hole there. Some of Dong's points are very, very easy to feel. And this is one of them. This is one of the points you can learn how to feel points with is 3 weights. Zusan Lee's stomach 36 is also very easy to feel. Beside 3 miles, easy to feel. So if you want to start learning how to palpate your points, it's really good to know your landmarks. If you know your point locations perfectly, then you should get yourself very close to the right area. And then you hone in on the exact point by marching in with your finger. I'll usually start in some of the point movies, you see me starting about a ½ inch above where I know the point is and marching my finger down incrementally into the point so that I'm absolutely certain when I land on the point. And the patient always knows too, actually. They'll usually say, oh, there it is, you know, before the needle. So first weight is halfway between the front edge of the fibula and the anterior tibial crest. What that also means is, since it's actually 1 sun anterior to the front edge of the fibula, that means halfway would be 2 sun altogether. So you can also move 1 sun lateral from the anterior tibial crest and look for it there. All right, it's on level with gallbladder 39, so that's 4 fingers above the tip of the external malleoli. And then our second and third weights are going to be found 2 sun or 3 fingers above, and look for the hole again, and 2 sun or 3 fingers above, again, look for the point. You can palpate this one. It's wonderful. So one more look at the photo, just so you can put it in your mind.
The nice thing about this is that when the patient has indeed true supraspinatus tendon problem, it will be tender on palpation. So they will almost tell you where it is. And in this video here, what I'm trying to show is that you can put a needle on either side of that tendon. And I'm showing you that by pushing very hard with my middle finger and inserting at the same time, patients feel the finger more than the needle itself. So it makes this technique a lot more comfortable and tolerable and pleasant for the patient. I want to mention that the lines here were supposed to mark the location of the supraspinatus tendon. Was done when the patient was sitting up, so the location has changed. So it is not meant to demonstrate where the needle in relation to the tendon. Okay. Now the last muscle we have to talk about for the rotator cuff is obviously the subscapularis muscle. And so the point heart one in the axilla can be thought of in 2 ways. It can be thought of as the subscapularis muscle or its nerve, the subscapular nerve, or if you go right in the center where the pulsation is, and the classic certainly alludes to there being a pulsation. So in other words, it's the neurovascular bundle. It's actually the brachial plexus that describing. Then you would be talking about targeting the brachial plexus. That's not the focus of this particular topic. Obviously, we'll focus on the subscapularis more, but I'm just including this in completeness sake. If you wanted to learn more about addressing other aspects of the upper extremity, 14-hour courses on healthyseminar.com that you can, I'm sure, spend weeks, if not months, trying to absorb this information. But for the purpose of this workshop, I'm going to call heart 1, not brachial plexus, but specifically the subscapular nerve. Now let's take a look at the anatomy of this. It is possible to separate the scapula from the rib cage enough to expose its interior surface so that we can target the subscapularis muscle that lies here. Obviously, you need to be between the pec major and the latissimus dorsi. If you weren't on the bone, you were too lateral, chances are you're going to put the needle in the latissimus dorsi. So this is why I emphasize that there's an absolute need to confirm this using a device like a pointer plus device, because otherwise you might think you're in the subscapularis, but 95% of the time, if you didn't test it, you're actually in the latissimus dorsi, which does attach to the scapula, which does help the scapula, but it's not going to do a darn thing to improving internal rotation with the subscapularis.
So we said that this movement regulates the shoulder when I did it on Valerie earlier. Now we need to give them something they can do themselves. So what approximates that is these 2 exercises from the heavenly stem, Neigong. The first one, or I'll actually do this one. The first one is we swing our arm on this diagonal, and then we turn and shift our weight and press down. And there's this sense of traction. I'm extending my spine up, which helps me to rotate. And then I press down, and the elbow and forearm sink together. We don't do this. We let the whole structure of the shoulder girdle sink together. It can really help to put one hand on our back to make sure that we're actually initiating the movement from the spine and dantian. So it's like a sensor that focuses our energy on the lower spine, Mingmen and dantian, to make sure that that's where we're turning from. So when I get here, I extend the spine. That allows me to turn. I shift the weight, and I press down. Okay, this we call the covering palm exercise, like you're covering something with a pot lid in this big arcing movement. And then we would do 10 or 20 or 30 repetitions of that. If my right shoulder is the injured shoulder, I still need to do the other side to balance it. And then we do the reverse of that. So instead of opening to the right, I'm going to cross to the left. That's like if I did the movement that I did on Valerie, I would eventually almost hit my nose with the bicep. But when I get to here, the body turns and the arm rises. And I turn, shift the weight, and press down to the right. Again, the whole forearm and hand sink. I don't lead here. So this works the whole shoulder girdle the same way I did when I was doing the Tuina arm rotations, but it's something the person does themselves, and it trains the shoulder to work with the hip. Right? You could see that the shoulder and hip are linked here. It trains the shoulder to connect to dantian, and it takes it through its range of motion. It also teaches the shoulder to move in harmony with the rib cage. That the rib cage has to lift, the spine has to extend to bring the arm up, and then the weight sinks, energy, chi sinks to dantian as we press down to the right. So those 2 exercises form one unit that regulates the movement of the shoulder.
This is the muscle that's being stretched, and I cannot stretch it anymore. So in many cases, or in some cases, more likely, the lung and the heart will also be involved. In some cases, the gallbladder and the spleen will be involved, or let's say a major player within it. So, to sum it up, one must always palpate in frozen shoulder case. If somebody comes with a frozen shoulder, it's not enough to ask him show me where the pain is, or show me where the pain is with one finger. That is what I normally do with other shoulder problems. In frozen shoulder, I need to do the examination and I need to also palpate. And I need to palpate areas that are not necessarily what the patient is complaining. So when somebody comes to my clinic, I don't just palpate the shoulder area. I palpate the lung area, I palpate the heart area, I palpate the intercostal muscle, the gallbladder, and the spleen. The difference is that if it's gallbladder, then the pain continues all the way up here. If it's spleens, then it stops, right? Because the spleen goes and it's like stops here. And I check, of course, the back and the bladder. How much is he involved in that particular case? Okay. Now, how do I treat it? Again, diagnosis. What's the next step? Finding a balancing meridian. So let me tell you a secret. Any of these two combinations, liver and spleen or liver and kidney, they treat all the meridians that are involved. So technically, if the problem goes more to the bladder part, I would do liver and kidney, because liver treats the large intestine, liver treats the lung, liver treats the small intestine, and then kidney will do the bladder, the heart, and the sanjiao. Okay, so I have them all. Well, of course, liver does the gallbladder too. If the problem does not involve the bladder line, I would go to liver and spleen. Okay, this is from my basic experience. But what points do I choose? So the points are like that. I would do the liver 4 towards 5 Ashi, and then either adds 5 towards 7 Ashi on the spleen. And if I use the kidney, I would do the same for the liver, and I would just use the kidney 3 towards 7, even a little bit higher than 7.
So let's show that one more time then.
Or just a little bit? Great.
Note I moved her head forward, but not so far forward that it made her muscles taut, just enough forward that it gave me some access. If it was too far forward, I would have had her bring it back. So then I did that first stroke line right on the bladder channel. You know where you would go up into, like, for acupuncturist, bladder 10? And then now more laterally up into near between bladder 10 and gallbladder 20. And then a lot more laterally still. So it should cover the whole neck.
So once again, the area that we wish to treat, the muscle, should be exposed but relaxed. So once again, the area that we wish to treat, the muscle, should be exposed but relaxed.
And it's not that many strokes to bring up this in the area.
That's great.
Okay. So that is the completed SAW on this patient. And again, note that she had was presenting with chronic Yang headaches, and her stasis was located actually more in the Shao Yang lateral aspect, the Yang point headaches, the lateral Shao Yang headaches.